Hello, I am welcoming you all to today's session. Today, we're going to have a discussion about 6 stories and we'll try to make a conclusion upon discussing those stories. So, without any further delay, let's dig in. So, now our first story. What we can see tree full of leaves, just like some rays of hopes. Okay, so trees are the poems that a earth writes upon the sky. So our first case, a patient with abdominal pain, and the pain was so severe that it was refractory to some extent, and it was not responding to the normal medication like the omeprazole or other PPIs or domperidone or even Anadol or nalbuphine, medication like that. So issue is that the pain was refractory and the patient is having some degree of vomiting. So whenever we get some abdominal pain, we do some investigation that mostly include the blood work. The blood work shows that serum lipase was way too elevated. It is 1,288. At that time, ultrasonography was done and it has shown a swollen pancreas. So we get 3 out of 3 criteria: severe refractory abdominal pain, also serum lipase is more than 3 times elevated, and alongside the ultrasonography showed some swollen pancreas. So it might be a case of acute pancreatitis. So it's a very common case. So let's go to the second story. What we can see now, we can see window. Okay, window to provide a path. Whenever we start at dark and there is always some light, and window could be a guide wire to that light. So there is a world out there, open window and it's there. So the issue is that now a patient consulted for a headache. Whenever we're getting a patient with headache, we need to do a lot of things, like particularly the full evaluation of central nervous system, wherever the patient is having any features of raised intracranial pressure or something like that, any worrisome feature present or not, that needs to be excluded. But the issue is that patient has got nothing. Okay, on abnormality, there's no abnormality. We did check for the blood pressure and it tends to get elevated like 150 or by 109. So there is both systolic and diastolic component is a bit elevated. We did some blood work at that period of time and serum creatinine has shown to be 1.8. So it was elevated at that period of time. The urinary was done and urinary shows no proteinuria. So what we get regarding the etiology of headache? So there could be the chance of hypertension. Hypertension could be a manifestation of CKD or could be due to acute kidney injury. Okay. And sometimes the hypertension is associated with AKI. So there could be both possibilities. So now let's go to our third story. What we can see? We can see some top tier of house, like some pinnacle or something called at the top. Okay. So the issue is that the whole world is wild at heart. And sometimes even it is weird at top. So let's check the third scenario. What we get there, a patient came to us with aphasia. Whenever we are getting aphasia, so there could be Broca's aphasia, there could be Wernicke's aphasia, and alongside the patient is having right-sided weakness. So it can be easily explained. Whenever the patient is having aphasia, so there could be dominant cerebral cortex involvement. It's mostly on the left side. So there could be obvious right-sided weakness. The issue is that it could be due to lower limb involvement, it could be upper limb involvement, it could be both involvement. But the issue is that we are getting upper motor facial nerve palsy. Alongside there is Hoffman positive. The plantar was not positive at that period of time. So the issue is that the patient is having facial muscle involvement, also upper limb involvement, also with aphasia. So there could be chance of a infarct in the middle cerebral artery. Okay, so whenever we are getting middle cerebral artery infarct, it tends to get involved in the upper limb and face. So it could be easily explained. So what we are getting here, we are getting a possibility of acute ischemic infarct in this scenario. So it's a very common case sometimes. We need to be, conscious about diagnosis these sorts of scenario. Now, the fourth story, what we are getting there, we're getting some window. Maybe window working as a door. Door to what? Door to the actual success. So whenever the opportunity doesn't work, you need to build a door, okay, so that you can find and snatch that opportunity. Now, the patient is talking about the opportunity. Patient is having some weakness in taking down the objects. And what we're getting on examination, we're getting some wrist drop, and there is no sensory lesion as well. So what we're getting, whenever we are getting the wrist drop, there's sensory involvement. There could be sensory involvement, but sometimes there could be absence of sensory involvement also. So the issue is that the patient is having radial nerve palsy. NCS was not done at that period of time, but clinically it was a radial nerve palsy. What we're getting, it's a mononeuropathy or as a part of mononeuritis multiplex. So that is our fourth story. Now, in the fifth scenario, what we are getting in the fifth story, we're getting a floor like a soil, and there is some flowers. Okay, there's some flowers and trees which is shine above the soil. So the issue is that it is like the seed put into the soil. The more on shows, the greater the harvest. So now we're going to have a long story. The patient is having some abdominal pain. Okay. At that period of time, he was underwent some ultrasonography, endoscopy of the upper GIT, including the CT scan of the whole abdomen. And all of these is unremarkable at that period of time. And if as everything is unremarkable, the patient was given some normal medications that include, some painkillers, some of course some GI friendly painkillers, some omeprazole, also some associated some drug to control the pain process. But the issue is that the symptom is not that much improved. Now the patient, as the patient is not improved, gradually he also develops some fever, some joint pain or symptoms like that. And sometimes he do mention that whenever the patient try to take some food, the pain is increased, but it's not that much. It's not that classical sorts of symptom. And occasionally patient did complain some loose stool, 1 to 2 episode of blood in that stool. At that time, the patient was underwent also complain weight loss. So whenever as the patient is having weight loss, it's a very important sign. We should do some general examination as well. So the issue is that there is no lymph node, there is no organomegaly. We did the ESR CRP, it was elevated. At that time, as previously endoscopy and ultrasonography, all were normal. It's again normal. And now the patient has undergone some colonoscopy. It has showed a ulcer in the colon. Okay. The issue is that at the time there's some biopsy taken from the ulcer and it was non-specific. But the consulting physician who was treating that patient, he was given some anti-TB with steroid. I don't know what was the rationality of giving that prescription, but the issue is that patient was a bit stable. Okay, most of the time he's having some on and off symptoms, and again after the completion of anti-TB, the steroid was continued because the symptom is not that much improved. So he suspected that there could be a possibility of Crohn's. But the issue is that it's not typical of Crohn's. Okay. So after, giving steroid, he was also having some on and off symptoms. But the issue is that as the patient was never underwent some angiogram or CT angiogram, because there could be another possibility we need to explore. So the angiogram or CT angiogram was done at a period of time, and it has showed some vascular narrowing, could be related to intestinal angina. And after that, patient was managed accordingly. So the story is that what we see is the different pictures from all over this picture. Okay. And we're not getting a full story. No. So now what our sixth story is the final story. And it is the whole picture. Sometimes we can see laterally or above or downwards, and we may miss the picture. So we need to take all of the scenarios, all of the pictures, and consider all of this fact as a whole story. So the issue is that we have discovered 6 cases: acute pancreatitis, we have discussed hypertension, we have discussed history of acute ischemic stroke, we have discussed mononeuritis multiplex, we have also discussed intestinal angina. What if all these 5 diseases can occur to a single patient? So that's our topic. That's the vasculitis. It can involve particularly polyarteritis nodosa, and it needs a criteria to be established. And it can involve all the medium-sized blood vessel, and it can involve any organ. Whenever it can affect the pancreas. It can cause pancreatitis. Whenever it can involve the the renal blood vessel. So it can cause hypertension, leading to renal infarction sometimes. It can cause stroke. It can cause MI. It can cause myelitis multiplex by involving the vessel of the nerves. And it can also involve the GI circulation as well. So the issue is that we need to be cautious about the polyarteritis nodosa or other vasculitis, in particular having this wide spectrum of involvement. As if we miss all this fact, this simple diagnosis can lead to a devastating consequences. Okay, so these are the pictures taken from 2 to 3 patients of long-standing PAN, which has been presented to us in the course of our training life. So, issue is that we need to think deeper when you are suspecting something bigger. Thank you so much.